All right, perfect. So skin and soft tissue infections, let's get going. So first and foremost, I'd like to start with a question. So we have a question over here. Please read and answer. All right, 6-year-old child presents with honey-colored crusted lesions around the nose. He's otherwise well, right? You suspect impetigo. Which of the following is most appropriate initial treatment? Correct, you guys wrote right. First, we go with topical treatments, right? So like topical mupirocin and stuff like that. First is topical treatments. So we go with topical treatments over here. So that's our step number one, right? And then after that, we move towards oral or IV and those things. And I will go over some of the key factors that determine why would somebody go with oral, why would somebody go with IV, and so forth. Okay. So our first topic, impetigo and ecthyma, right? So these are again, most of these are like soft, superficial infections, skin infections, right? So impetigo, you guys know, honey colored crusted lesions you see mostly around face, lips, etc. That's one, right? And ecthyma is slightly deeper than that. So sometimes you can see ulcers and stuff as well. So in both of these things, it's clinical diagnosis, okay? You don't need culture as such. You can go for it, but you don't need culture as such, okay? And topical therapy is usually the first line. Oral therapy you can give in cases such as somebody who has diabetes or other immunocompromising conditions. And we'll come back to that later on. Treatments, mupirocin and doxy and clindamycin and so forth, right? For ecthyma, like I said, which is slightly more severe than impetigo, we go oral. Simple, easy stuff. Good. Let's go next. Very good. Again, easy question. 34-year-old man comes with painful boil on his thigh, no fever, systemic symptoms, etc. What is the main treatment over here, right? So most of the times when we see that somebody has an infection and those sorts of things, we jump onto antibiotics, right? And skin infections we identify by a few ways, right? So clinical examination or it is many times clinical diagnosis. So how do we know that somebody has some infected skin lesion? Any guesses? Like, how do we know? Can you type it out? Like, somebody has come with some skin stuff. When can you say, like, oh, yes, this is infected? What are some of the clinical features? Very good, very good. So if there is erythema, right? If it is swelling or pain, right? If there is some sort of, let's say, like a boil or pus dot or something that you can see over there, right? We suspect that there is an infection going on. Okay. So clinical features are the key in terms of diagnosing these infections. Good, good. That's one. Second, treatment. So treatment, we talked about topical ones with erysipelas and so forth, right? And then we have oral treatments, right? So these are the antibiotics, okay? These are the antibiotics. However, right? However, what happens sometimes is these antibiotics are not able to reach where the bacteria are, right? They're not able to reach where the bacteria are. So that depends on blood supply and so forth. So in those cases, we have other methods of treating an infection. What are some of the other methods? Incision and drainage, right? Incision and drainage. You incise it, you drain the pus or whatever it is. All right, now you have opened up the cavity, right? Now you have opened up the cavity, and now the pressure fluctuations, all of that has gone down. So easy penetration by antibiotics, right? Easy penetration. So source control, everybody, is very important for QE1 exam, for your NAC or SKI, whichever exam you are giving. Source control, right? Source control is very important over here. Okay. All right. So incision and drainage, the answer. So again, going over it, you have abscesses, right? You have furuncles, you have carbuncles, and so forth. Okay. And what each of these means, you can Google the pictures, right? Abscesses, you know what it is. Furuncle is like one follicle infection. Carbuncles are like multiple follicle infections and so forth. So this you can Google. So incision and drainage, main treatment, right? You can consider IV antibiotics if you have systemic signs. So when you have like fever, right? Temperature going high, right? Rigors, chills, those sorts of things. Okay. So you need IV antibiotics in those cases. And then if you suspect that this person might be positive for MRSA, methicillin resistant Staph aureus, okay, like let's say antibiotics in the hospital and so forth. If you suspect that there is MRSA going to be here, then you can consider methicillin resistant Staph aureus or MRSA targeted therapy like clindamycin, doxycycline, Septra, Bactrim, whatever names you remember. Those are the main targeted therapy for Staph. Okay, Staph aureus. Those are the targeted therapies for that. Good. Okay. Now, anytime somebody presents with skin abscesses that are recurrent, right? Do we get those cases, everyone? We are like, oh, this kid came in and had an infection and then came in after a month again and they got infection and stuff like that. Do we get that, everyone? Yes, no, yes, no? No, yes. Yeah, right. We get it quite common, right? Like we get it quite commonly where they come in multiple times. So in those cases, we need to identify underlying causes, right? We need to identify underlying causes. So what are some of the underlying causes? So you can have something like a skin condition where there is break in the skin, like eczema or something can happen, right? Or fungal infections, right? Can fungal infections like tinea and stuff predispose people to more bacterial infections, everyone? Yes, no, yes, no? Tinea and stuff, can it predispose to bacterial infections? Yeah? Good, good, right? So fungal infections that breach the integrity of the skin. What else you have? Eczema or dermatitis that breaches the integrity of the skin, right? What other things can breach the integrity of the skin where the skin is not the greatest? Any guesses? Where our skin, the integrity is compromised. What are some of the conditions that you can think of? So eczema can be one, fungal infections. Very good. Chronic venous insufficiency, right? Chronic venous insufficiency. So somebody has come with like varicose veins, right? And has stasis, dermatitis, stasis, ulcers, and whatever you can think of, right? Chronic venous insufficiency. So that is the vein part. Can we have arterial insufficiencies? Yes, no, yes, no? Yes, we can have arterial insufficiencies too, right? What is that called? That is called peripheral arterial disease, right? Peripheral arterial disease. Okay. What is a very common cause of peripheral arterial disease? Common cause of peripheral arterial disease is metabolic, right? It is metabolic. All the poutines and the pastas and stuff like that we eat, right? Metabolic. So peripheral arterial disease, cholesterol, whatever you need to know, very common cause of that, right? So these are some of the underlying causes that you need to address before you move forward, right? It's like, oh, this person has an abscess. Like, okay, all right, here you go, cephalexin, bye, done. No, right? You need to see why is this abscess occurring. So that's important. Q1 tests that, very important. You need to understand the underlying cause over here. right? Underlying cause over here. So that's something we talked about, skin conditions, right? Now we have conditions that in general lower our body's immunity, right? We have conditions that in general lower our body's immunity. So diabetes is one, right? Like all of you guys said, diabetes is one which can lower our body's immunity. What are some of the other conditions? HIV is another one, right? HIV can do that. Okay, good, good. Anything else that lowers our body's immunity? Uncontrolled diabetes, HIV. What else? Immunocompromised state. Somebody very good, somebody who's on chronic steroids, right? Or immunomodulators, right? Crohn's disease and ulcerative colitis and rheumatoid arthritis and you name it, right? So all those conditions put you at high risk, right? All those conditions put you at high risk, right? So immunocompromising conditions, that's another one that can put you at a very high risk, right? So those are the things that are the second category that we need to know for this, right? Third category is socio-economic factors, right? Socio-economic factors over here. So what are some of the socio-economic factors? Socio-economic factors include homelessness, right? Not able to take care of the skin really well, or prisoners, right? Living in closed encounters and stuff like that, right? So those are some of the categories where the skin can be affected too for all these conditions, right? So these are very, very important categories to know of underlying causes that can lead to these things, right? Cushing, scabies, etc. They are not very common, right? They are not very common. Sure, they can lead to infections, but our primary goal would be something to identify the top priority ones, right? And those would be like eczema, very common over here, tinea, very common over here, diabetes, and those ones. Good. Okay, awesome. So that's your underlying causes. In any case where you identify things like that, right? You go for your typical incision and drainage, right? You go for antibiotics, etc. And then we have a decolonization regimen for Staph aureus. Oh my God. Did you guys know about this? Right? Did you guys know about this? Decolonization regimen for Staph aureus? Yes, no, yes, no. No? Oh my God. This is a high yield stuff, right? This is high yield stuff. So you have 5-day decolonization regimen with mupirocin, which is intranasal. Wow. Bactroban or mupirocin, which is intranasal, right? Then you have chlorhexidine washes, decontamination of personal items. You know, this is your typical health promotion and illness prevention. Health promotion and illness prevention. Do you guys know about this? This is like one of the blueprint categories for QE1 and NAC health promotion and illness prevention. Okay, so that's something you need to know because this can be a high yield question as well for your QE1 exam. And then you have immunodeficiencies in kids or neutrophil disorders, etc. if you have multiple recurrent skin abscesses. Good. Moving on, we have cellulitis, erysipelas, again, similar things. We don't do culture. These things a lot of times are caused by strep, okay? So we go with streptococcal antibiotics, right? Streptococcal antibiotics. And if they are severe, again, fever, systemic signs, immunocompromised state, etc., then we go and add your staph coverage to it, staph coverage to it. What else? We always treat the underlying cause, right? So the key message from today's lecture for you guys is to treat the underlying cause, okay? To know the underlying cause and to treat the underlying cause. Not that, oh my God, cellulitis, I am going to blast it with meropenem. I am going to blast it with meropenem. Well, guess what? If there is poor blood supply to that area, if there is abscess and stuff on that area, if there is venous stasis and stuff going on, You know what is Staph aureus going to do? You know what is Streptococcus bacteria going to do? It is going to eat away all your meropenem and all your vancomycin. It is going to eat it for lunch. Okay? It is going to eat away all your antibiotics just like that. So, important thing is treat the underlying cause. Everyone agrees? Yes, no, yes, no? Yes, no, yes, no. Okay, all right. Good, good, very good. Okay. Um, in cases where there is cellulitis, but inflammation is severe, which is affecting quality of life of a person, you can consider corticosteroids. Okay, this is not a norm. We don't normally give corticosteroids, but they may be considered. Okay, so just FYI, they may be considered. Good. This is something we already talked about, right? What are some of the underlying conditions? So you can have obesity. Oh, right. Somebody has a big stomach and comes and doctor, I get this redness and infection and smelly discharge underneath my tummy. Well, guess what? It's a big penis, right? Then you have eczema. We talked about venous insufficiencies, anatomic issues, right? People in wheelchair, right? They have a lot of infections that they can happen. Why? Because they're not mobile as much, right? And then tinea and stuff we talked about as well. Good. You can consider prophylactic antibiotics in these cases. All right. Then let's switch gears and move to surgical site infections, right? Something which is surgical. So anytime when there is a surgical site infection, we follow certain steps, right? We follow certain steps. Let's say somebody had, right? Let's say somebody had a surgery. Let's say like appendicectomy or something. Okay. And now you see that the wound is oozing, right? You see that the wound is oozing pus, nothing else. The wound is oozing pus, right? So anytime we have a surgical infection like this, what is our number one goal? What is the take home message from today, everybody? Take home message from today is treat the underlying cause, right? So anytime there is a wound that is oozing pus, what do we do? First and foremost, we make sure that we are draining the pus well. Okay. What else we are making sure? We are making sure that we are taking out any foreign bodies. Okay. Any foreign bodies. So what does a foreign body include? A suture. Okay. So if there's a suture material, if there is anything like a drain or anything like that, we take it out, right? We take it out. Why? Because that is going to harbor the bacteria, right? That is going to harbor the bacteria. So these are our primary things that you get tested on, right? Once all of these things is done, then fine. Vancomycin, meropenem, okay? I am going to go with carbapenem. How about that? It's like, oh, really? Yeah. Me, I'm going to go with linezolid. It's like, wow. Okay. But before that, consider these other things first. Okay. All right. Let's do this. Let's do this question. All right. So how many? Oh, two people have answered yet. Okay, 45-year-old male presents with rapidly spreading leg pain out of proportion to physical findings. High fever, hypotension, all of these things are going on. right? High fever, hypotension, all of these things are going on. So what are we thinking over here, everybody? What are we thinking? Leg pain out of proportion, right? Pain out of proportion, fever, systemic signs, hypotension. What is the diagnosis that we are thinking, everybody? What is the diagnosis? Do we know the diagnosis? What is it? Any guesses? Yes, no? Compartment syndrome. Okay. That is one you guys are thinking compartment syndrome. Anything else? That is one diagnosis I got. Any other diagnosis that you guys can think of? Very good. Necrotizing fasciitis, or we can call neck fash. Okay. Anything else you guys can think of? Anything else? Okay. Let's say cellulitis, but cellulitis which is not simple. All right. So it is severe cellulitis. Okay. Severe cellulitis. Right. What else? Sepsis. Okay. Sepsis. Septic shock. Okay. Septic shock due to local skin infection, right? Septic shock due to local skin infection. Okay. All right. Thrombosis. Well, thrombosis is not a diagnosis. It can be deep vein thrombosis, right? Deep vein thrombosis. But that won't cause like hypotension and stuff like that, right? So chance relatively low, right? Relatively low. Anything else you guys can think of? So these are the differential diagnoses that you know. Can we for sure say that this is compartment syndrome? Can we for sure say that this is necrotizing fasciitis? Can we for sure say that this is septic shock with local infection and stuff like that? Can we say 100% this is this? Can we say that? Yes, no, yes, no? No, exactly. We can't say that, right? We cannot say 100% for sure. But what can we say over here is something really bad is going on, right? Something really bad is going on with what? With the leg. Something really bad is going on with the leg, right? Do we know what's going on? We don't, right? So do you think antibiotics will help us? We don't know what's going on with the leg, right? So do you think antibiotics will help us? No. No, right? I mean, it will help for sure. It will help. It's not like it won't because the patient has fever, so antibiotics will help. But what is the step number one over here? This is what is this? This is called a surgical emergency. Okay, this is called a surgical emergency. What do we do in surgical emergency? What is the most important step for us in surgical emergency? The most important step for us in surgical emergency is what? Is to get the surgeon. That is the most important step for us, right? Is to get the surgeon. Why? Because surgeon is the only one who can fix the pain part, right? Surgeon is the only one who can fix the pain part, right? Now, if over here, right, if over here they had given like IV fluids and stuff like that, right, IV fluids and stuff like that, then that would be our answer because the patient is hypotensive. We need to stabilize the patient. We need to make sure that you do your ABCs and stuff like that, right? So if they had given IV fluids, fine, they didn't, right? So what is our most important step over here is urgent surgical consultation. We need to fix this surgical badness. Does that make sense, everyone? Yes, no, yes, no? Right. Looks like necrotizing fasciitis, right? It could be something else as well. We just don't know what it is. We just know it is something really bad happening with the leg. Looks like it's a surgical emergency. I have to got to call the surgeon. He needs to come and open up and see like, oh my God, there's no blood supply to these muscles and stuff, right? What's happening over here? Necrotizing fasciitis, right? Neck fascia. Or they open it up and they see like, oh my God, this is compartment syndrome, right? Compartment syndrome, which may be some infection, who knows, right? Or severe sepsis from local infection, right? All of this could be present. So, surgical consult, number one, most important step. Good. All right. So, for skin conditions, there are some conditions which are red flags, and we discussed about them, right? So, necrotizing fasciitis is one. It's a clinical diagnosis. When you look at the leg, you can't say it's necrotizing fasciitis or not. All you can say is, this doesn't look good. I need to call the surgeon, right? So, urgent surgical consult, step number one. Step number two, you start on broad spectrum antibiotic. Okay. Second one is pyomyositis. Do you guys know about this? Pyomyositis? Pus in the muscle, in the muscle fibers. There's like an abscess and pus and stuff like that. And it goes through layers and it goes through fibers, muscle fibers. That's pyomyositis. Homeless, prisoners, IV drug users, diabetes, rheumatoid conditions. When there is a mixture of all of these, superficial skin infections can sometimes go in and do this, right? Sometimes can go in and do this. Again, can you diagnose it like, oh yeah, this looks like pyomyositis? No, right? All you can say is it doesn't look good. I need to call the surgeon. I need to arrange for drainage. That's the thing, right? MRI, CT scan, you can consider for diagnosis, but many times you don't have time for it, right? So it's a diagnosis on the operating table. Okay. Then you have clostridial gas gangrene, right? This is more so um, in like wars and stuff, right? In wars and stuff, you find this clostridial gas gangrene. Again, same thing. It's caused by Clostridia. Debridement primarily is a treatment for this. Okay. Okay. Let's do this question. All right. Good trial. 70-year-old man with liver cirrhosis bitten by a cat. Nothing else is going on. What is the best next step, right? So it's just like a completely healthy 35-year-old guy, cat bite or cat scratch or whatever it is, nothing else going on. You can maybe consider topical, right? However, given that this person has liver cirrhosis, which is an immunocompromising condition, we will start with oral antibiotics, right? We will start with oral antibiotics. What is the best antibiotic? Amoxiclav, right? Amoxiclav is the best antibiotic over here. Good. All right. So animal and human bite wounds, right? So which is worse, everybody? Is animal bite bad or human bite bad? Which is bad? Animal bad or human bad? And I'm talking about like dogs and cats. Dogs and cats. I'm not talking about like rabies from raccoon and stuff like that. Good, good. Human bites are bad, right? Human bites are bad. Why? With tons of bacteria in our mouth, right? We eat everything, do everything, all of that. So tons of bacteria. So that's why human bites are bad compared to domestic animals like cats, dogs, etc. So in high risk patients like immunocompromised and liver disease and stuff like that, antibiotic prophylaxis, amoxiclav, you can use tetanus, rabies, etc. as needed, right? Good. And we talked about immunocompromised patients before as well, right? You have to think more than just skin and soft tissue infection. You have to think, is this a fungal infection gone bad, right? Is this maybe like a drug reaction or maybe contact dermatitis or something? Very important. You can do biopsy, aspiration, etc. in these cases as well, right? Cancer patients are another immunocompromised patients. They don't have the same level of immune response like a normal person. So you have to have high index of suspicion and you provide broad antibiotic coverage, right? Broad antibiotic coverage. Good. Perfect. So in summary, we do emphasis on individualized care, guideline directed antimicrobial selection based on your local sensitivities. Local sensitivities. What does this mean? This means like is like E. coli in Toronto, is the E. coli same as the E. coli, let's say in Mumbai? Is the E. coli in Toronto same as E. coli in Mumbai? No, right? It's different, right? Why? Because the bacteria are different, the resistant patterns are different. So it's very important to know local sensitivities, right? Where I was working in northern British Columbia, the sensitivities of some of the bacteria were different compared to the sensitivities over here in East Toronto and stuff like that, right? So you need to know that antibiograms and those things when you're practicing. Okay, not for the exam, but when you're practicing, you need to know the local antibiogram so you know what to prescribe for what types of cases. Okay, let's pause here.